Okay, so welcome back to this next video in which we are discussing the bronchodilators as a treatment for asthma. Okay, so we're currently looking at the pathology of asthma. So we've seen that when you are exposed to this allergen for the second time, and we're of course looking specifically at the pathology of allergic asthma. Okay, so when you're exposed to the allergen for the second time, or any time after the initial exposure, then what's going to happen is it's going to bind to the IgE on the surface of the mast cells, and then it's going to cause the activation of those mast cells, and the mast cells will degranulate, releasing histamine. They're also going to start producing many pro-inflammatory mediators such as the cysteinyl leukotrienes, leukotriene B4, and also tumor necrosis factor alpha. Now, this is what's going to cause the asthmatic attack, okay? So, what happens is the asthmatic attack can be divided into two phases: the immediate phase and then the late phase. Okay, now, the mediators that are responsible for the immediate phase are histamine, leukotriene B4, and cysteinyl leukotrienes, whereas tumor necrosis factor alpha is going to cause the late phase of the asthmatic attack. So we'll start off with the immediate phase. So, firstly, what's going to happen is these mediators, histamine and cysteinyl leukotrienes, are going to diffuse backwards towards the smooth muscle cells, which are lining the bronchus. So remember, underneath the lamina propria, there was this layer of smooth muscle cells, and what's going to happen is from the lamina propria, where the histamine and the cysteinyl leukotrienes are being released by the mast cells, these mediators are going to make their way backwards to the smooth muscle cells, and they're going to cause contraction of those smooth muscle cells. Okay, so if we draw a smooth muscle cell here, okay, on the surface of these smooth muscle cells, you have receptors for histamine and also for cysteinyl leukotrienes. Okay, now they are both GQ coupled receptors. So the histamine receptor that you have on the surface of smooth muscle cells is H1. Okay, so histamine will come and bind to the H1 receptor, and this is a GQ coupled receptor, which will cause the release of intracellular calcium stores and the contraction of the smooth muscle cell. Okay, similarly, you have cysteinyl leukotriene receptors on the surface of the smooth muscle cells. Now, there are two main types of cysteinyl leukotriene receptors that are known: the cysteinyl leukotriene receptor 1 and the cysteinyl leukotriene receptor 2. Okay, now these are both found on the surface of bronchial smooth muscle cells, and the functional significance of the two is not really known. Okay, so there are cysteinyl leukotriene receptor 1s, and there are also cysteinyl leukotriene receptor 2s. Okay, now these are both GQ coupled, okay, so when you activate them, it's going to lead to the activation of the GQ pathway, okay, and then the release of the intracellular calcium stores, which will cause the contraction of the bronchial smooth muscle cell. Okay, so the cysteinyl leukotrienes are going to come and activate the cysteinyl leukotriene receptors. Okay, so then what's going to happen is that these smooth muscle cells are all going to contract, and that's going to cause the constriction of these rings of smooth muscle cells which surround the bronchi, and that will cause the constriction of the airways. Okay, so this is going to lead to bronchoconstriction. This is going to happen all over the place. So in all your airways, in all your bronchi, you're going to now get bronchoconstriction. Now this is going to lead to obstruction of the airways and difficulty with breathing. Okay, but it's not the only thing that leads to obstruction of the airways. There is another thing that is going to make matters worse, basically. Okay, so in addition to this, what histamine does, okay, is it's going to act on the blood vessels which are within the lamina propria. Okay, so remember, in the lamina propria we have these mast cells, but we also have these blood vessels. So the histamine is going to act on the endothelial cells of these blood vessels. Now, in the lamina propria you have very small blood vessels, but you have three different types of blood vessel. Okay, you're going to have tiny little arterioles, and I mean these are tiny blood vessels. Do not confuse arterioles for arteries, which you learnt the structure of in anatomy. Okay, these are tiny little blood vessels. Okay, and the arterioles will branch into capillaries here, and then the capillaries will reconverge into post-capillary venules. So, the terms arteriole and venule can actually cover a broad range of size of blood vessels. So, to emphasize that you mean the arterioles which are just prior to capillaries, you write terminal arterioles. So this is a terminal arteriole. Okay, then it divides into capillaries, which are absolutely tiny little blood vessels. Okay, 1 cell thick. Okay, and then finally you have post-capillary venules, which again are tiny little blood vessels. So these are the venules that are immediately after capillaries. Okay, so these are all tiny blood vessels that you'll have in the lamina propria. Okay, now, the terminal arterioles, they have a layer of smooth muscle cells around them, whereas the capillaries and the post-capillary venules, their walls literally just consist of endothelial cells sitting on basement membranes, so they have pathetically thin little walls. Okay, so what's going to happen is that histamine is going to act on the endothelial cells in these 3 types of blood vessel, and it's going to cause what's known as type 1 activation of those endothelial cells. Now, type 1 activation occurs extremely rapidly. Within a few minutes, the endothelial cells will have undergone type 1 activation after being stimulated by histamine. And again, the receptor on the endothelial cells that responds to the histamine is an H1 receptor. So via H1 receptors, they're going to trigger type 1 activation. Okay, now what does type 1 activation lead to? Well, it leads to relaxation of the smooth muscle cells surrounding terminal arterioles. Now you might think that's quite odd, because histamine caused contraction of the smooth muscle cells surrounding the bronchus, but basically it's going to cause the endothelial cells to make a huge number of substances which will cause dilatation of the smooth muscle cells which surround them, basically. So you do get vasodilatation, okay, which means that the arterioles open up and allow more blood to flow through them, which means that the amount of blood that will be flowing through the lamina propria goes up. In addition, the endothelial cells in the capillaries and the post-capillary venules, they undergo contraction and they open up little gaps between neighbouring endothelial cells, and this allows fluid from the blood to leave the blood, okay, and go into the lamina propria, into the interstitial fluid. Okay, now with this fluid comes a huge number of proteins from the blood that would never usually leave the blood, such as complement proteins, coagulation factors, the components of the kallikrein-kinin system, which are all going to be important in helping deal with a pathogenic infection if there was one present. And that's what we're initiating, really. Everything we're doing is basically trying to deal with an invading pathogen, except that the problem is we don't have an invading pathogen. We are initiating all of this because the mast cells were tricked into thinking that the allergen was dangerous by having this IgE mounted on their surface that was against the allergen. Okay, so we're going to get the buildup of what's known as an inflammatory exudate, which is this extra fluid and proteins that have come out of the blood that would never usually be allowed to leave the blood. Okay, now what's the overall outcome of this inflammatory exudate? Well, it's come to try and help, but it doesn't help at all. It actually makes things worse, because if you can imagine pumping in a whole new, if you imagine stuffing the lamina propria full of inflammatory exudate, it's going to swell. It's going to swell huge, okay? And that's going to push in on the basement membrane with the epithelial cells sitting on it, and it's going to cause the obstruction of the airway even more, basically. So the smooth muscle cell layer here in vivid purple has contracted, and now also the lamina propria is swelling. So both of these things are going to lead to the constriction of the actual airway here and obstruct the flow of air through that. Okay. In addition, you're also going to get leukocyte recruitment from the blood. Now, the main leukocyte that you start recruiting when endothelial cells have only undergone type 1 activation is neutrophils. So they can't really recruit that wide a repertoire of leukocytes, but they can recruit neutrophils, okay? And you're going to start moving neutrophils from the blood into the lamina propria, and these are also going to contribute to the swelling of the lamina propria. Okay, in addition, leukotriene B4, okay, here, which did not activate the cysteinyl leukotriene receptors, remember it was not a cysteinyl leukotriene, it does cause neutrophil recruitment. It's incredibly powerful at increasing neutrophil recruitment. So histamine leads to type 1 activation, which would lead to neutrophil recruitment anyway, but if you've got leukotriene B4 as well, then that's going to massively increase the number of neutrophils that you recruit. So it's an incredibly powerful agent at increasing the recruitment of neutrophils to a site. So if you have very high leukotriene B4 levels in the interstitial fluid somewhere, that leads to a huge number of neutrophils ending up at that site. Okay, so you bring in neutrophils, you produce the inflammatory exudate, you vasodilatate. Okay, so this overall leads to the swelling of the lamina propria. That's the overall result of this. And both the swelling of the lamina propria and the bronchoconstriction of the smooth muscle layer both lead to the obstruction of the airway, okay? And this is the problem. This is what causes the asthmatic attack. This is the beating soul of an asthmatic attack, that the airways end up constricted and obstructed, okay, and you can't breathe properly, okay, so this leads to wheezing basically because you're forcing air through a much narrower tube, so it causes wheezing, okay, is one of the key symptoms, that your breathing sounds very funny because you're forcing air for a very narrow tube. In addition, you're going to have shortness of breath, you're going to be struggling to breathe basically. And in severe cases, in severe asthma attacks, what this can lead to is it can lead to hypoxemia within the blood, too low oxygen levels within the blood, and then that can potentially lead to asphyxiation. Okay, so asphyxiation is the fancy word for dying because of lack of breathing, basically, because of a problem with breathing. Okay, so severe asthmatic attacks can lead to asphyxiation. Okay, so that's the immediate phase of a asthmatic attack. Now let's talk about the late phase. Okay, so the late phase, what triggers the late phase is this tumor necrosis factor alpha that the mast cells have released. Okay, so tumor necrosis factor alpha will also diffuse to the endothelial cells or the blood vessels within the lamina propria, and it's going to activate them as well, but it's going to trigger what's known as type 2 activation of endothelial cells. Okay, so type 1 activation of endothelial cells occurs within minutes, basically. Okay, it takes a few minutes, and that's because it doesn't involve any changes in gene expression, so you don't have to produce any new proteins to type 1 activate an endothelial cell. Whereas type 2 activation takes hours to occur, okay? And the reason is because it changes gene expression within the endothelial cells. Now, the important thing that type 2 activation is going to do, as far as the late phase of asthma is concerned, is that it's going to lead to these endothelial cells being able to recruit a much broader repertoire of leukocytes. So remember, type 1 activated endothelial cells, their only ability really was to recruit neutrophils, whereas type 2 activated endothelial cells can recruit all sorts of much fancier white blood cells. Okay, so they're going to start recruiting T helper 2 cells into the site, okay? Now, you might ask, well, where did these T helper 2 cells come from? Why were they in the blood in the first place? What are these T helper 2 cells armed against? Okay, are they armed against an allergen fragment, i.e. a fragment of our allergen that we've just breathed in which has caused the asthma attack? Well, the answer is we don't know. The thing is that you wouldn't expect the T helper 2 cells to have gone up in the blood that quickly. Okay, so usually it takes time to activate a memory T cell. Okay, it's quicker than the primary immune response, but the secondary immune response still takes longer than you've had, basically. So we don't know where these T helper 2 cells come from, and we don't really know whether they are actually armed against the allergen that has caused the asthmatic attack, or whether they're just T helper 2 cells that were floating around in the blood that happen to get recruited by these endothelial cells. Anyway, they come into the lamina propria and they start causing havoc. Okay, so they start producing interleukin-5, IL-5, and also another chemical known as, well, another protein known as granulocyte monocyte colony stimulating factor, which is, granulocyte macrophage colony stimulating factor, which is also known as colony stimulating factor 2. So let me write its name out in full. So granulocyte macrophage colony stimulating factor. Okay, now these two proteins, interleukin-5 and granulocyte macrophage colony stimulating factor, what they're going to do is they're going to lead to the recruitment of another type of white blood cell from the blood. Okay, so this is granulocyte macrophage colony stimulating factor. Okay, and the type of white blood cell they're going to recruit from the blood is an eosinophil. Okay, so these are going to lead to an eosinophil recruitment. Now, we're not totally sure how this leads to eosinophil recruitment. We don't know whether it acts on the endothelial cells of the blood vessels and activates them to start recruiting eosinophils, or whether it acts on the eosinophils directly. We think it probably acts on the eosinophils directly and appears to activate them so that they can now be recruited by the endothelial cells, but we don't know. What we do know is that if interleukin-5 and granulocyte macrophage colony stimulating factor are very high in the interstitial fluid of an area, then that leads to eosinophils being recruited into that area. So you end up with loads of eosinophils in that area. So that's the experimental observation, that if interleukin-5 and granulocyte macrophage colony stimulating factor are high, then eosinophils end up recruited there. Okay, so let me just discuss eosinophils for a moment. So, eosinophils are a type of granulocyte, okay, and they have an odd-shaped nucleus. Let me show you the shape of their nucleus. So they have this bilobed nucleus like this, okay, where you have these two lobes with a tube connecting the two lobes. So this is an oddly shaped nucleus, okay. And they are called eosinophils because if you stain them with the red dye eosin, they take up eosin fantastically. So when stained with eosin, this is what they look like, basically. If we colour this in bright red. So they're usually very distinguishable histologically. If you look at a histological slide, eosinophils can usually be seen very easily because they're often compared to a burnt sunglasses-clad face, basically. So their nucleus is like the sunglasses, and then the rest of their cytoplasm is like the sunburnt face, basically. Okay, so this is what an eosinophil looks like if you ever see an eosin-stained eosinophil. Okay, and they are a type of granulocyte because they have little granules within their cytoplasm. So there are 3 leukocytes that are all counted as the granulocytes. The granulocytes are eosinophils, neutrophils, and then also basophils, which don't really do that much in the immune system. They're one of the cells that is least present in the blood, and which, unless you're looking at specific diseases where they're involved, you'll never see. Okay, these eosinophils, what do they have within their granules? Well, basically they have horrible proteins within those granules. Within their granules they have 2 proteins. One is known as major basic protein, okay? The other is known as eosinophil cationic protein. Okay, so major basic protein is often abbreviated to MBP, and eosinophil cationic protein is often abbreviated to ECP for short. Okay, so eosinophils are one of the most powerful cells that the immune system has. These are the cells that if you have a multicellular parasite, such as a parasitic worm, these are the cells which the immune system recruits to deal with that, because they are the only cells which stand a chance against a multicellular parasite. Okay, and what they will do is they'll go over to this parasite and they will release these granules containing these two foul, horrible proteins, major basic protein and eosinophil cationic protein, which are basically just cytotoxins. They kill whichever cell they come across, basically. So you release these horrible toxins onto the parasite to try and kill it. So they are an incredibly powerful and also dangerous cell within the immune system. So it should be ringing alarm bells that we are bringing these things in to deal with this allergic response that is against nothing, basically. It's against pollen or whatever. Okay, so what do these things now do? Well, the same molecules that recruited them to that site are now going to stimulate them. So interleukin-5 and granulocyte macrophage colony stimulating factor both recruit the eosinophils to the site, and they also activate them. And the eosinophils start releasing their granules, which contain major basic protein and eosinophil cationic protein. And this leads to the killing of the cells within the bronchi, okay? And the cells that get hit hardest are the epithelial cells, which are sitting, remember, just above the lamina propria. So what gradually starts to happen is you lose epithelial cells as you have more and more asthmatic attacks. So every time you have an allergic asthmatic attack, it will result in one of these late phases where you are going to end up destroying a few more of your epithelial cells. Okay, so gradually, as you have more and more asthmatic attacks, then every time you have an asthmatic attack, you're getting more and more damage to your bronchi. Okay, and what this can eventually lead to is it leads to the exposure of neurons which are within the lamina propria to the airway. So there are neurons, sensory neurons within the lamina propria, and if you damage the epithelium enough, they can end up exposed to the airway. Okay, and this is then how allergic asthma can propagate into non-allergic asthma, because now if you inhale things like cold air or environmental pollutants such as sulfur dioxide, nitrogen dioxide, or horrible chemicals in cigarette smoke, these can all stimulate these sensory neurons which are exposed to now the contents of the airway, and these neurons will then trigger off the same reaction that the mast cells triggered off. They'll do it in a different way. They won't release the same mediators as the mast cells, but they will trigger the same things. So they'll trigger contraction of the smooth muscle cell that surrounds, the smooth muscle cell layer that surrounds the bronchi. They'll trigger neurogenic inflammation, so they'll trigger the activation of the endothelial cells, and therefore the swelling of the lamina propria. So they too can trigger asthmatic attacks. It's through different mechanisms than the mast cells, but effectively the overall outcome is the same thing. Okay, so that's how allergic asthma, if you have it enough times, can lead to non-allergic asthma. Okay, right. So what else do the eosinophils do? Well, one final thing. They also produce cystenyl leukotrienes. Okay, and these cystenyl leukotrienes, which are leukotriene C4, D4, and E4, those continue to activate the cystenyl leukotriene receptors on the smooth muscle cells of the bronchi, and therefore maintain somewhat of a constricted bronchus, okay, and therefore maintain to some degree the bronchoconstriction. It's not as bad as in the immediate phase because we're no longer releasing the tons of histamine, but it maintains to some extent the bronchoconstriction. Okay, so in the next video then now, we'll turn our attention to how we can use bronchodilators in the treatment of asthma.